Sub-Saharan Africa, we have on average about 30,000 one doctor, whereas in North and in Europe and thereabout is around 3,000 to a doctor. And it is the same for nurses and all health workers. So it means that our health system cannot deliver these interventions. We need to improve access to these medicines. And how are we going to do that? We had to look at alternatives. So what role do peripheral health workers have in delivering these interventions? If you ask them to come for these medicines in hospitals, it will not work. So we needed to introduce what community-directed treatment approach, drug distribution. And in some pilot studies that were done in Ghana and Kenya, when we asked the health service to deliver these medicines, our coverage was in the order of about 60% in Ghana and around 55% in Kenya. And this is just a small catchment population around health facilities. But when we use other health auxiliaries, then the coverage went up. So, country, we cannot run away from the fact that we need auxiliary staff to deliver our interventions. We can continue to play ostrich and say that we don't want these people because they are lowering standards and all the things that we talk about. The reality on the ground is that we do not have people to deliver these interventions, and therefore we need to allow these people, train them, incentivize them, and make sure that they deliver these according to the standard operating procedures that we provide for them. Simple. You do a measuring poll, you give it to the community, they decide when to do the distribution collection system, and you have a regular community level, and it will amaze how brilliant these people are, how smart they are. Of course, we need to be careful and also remember that there could be inadvertent exposure, because drugs that are used at the community level can have a problem. In fact, in a study that was in the Western region at a point in time, we found out that about 14.8% of pregnant women who were not supposed to take medications were taking them. And the reason most of the time that as part of our community management, we were saying that you don't have to use these medications because it can be dangerous in pregnancy, in as much as there have been no clear studies to show this. The basic principles of management of pregnancy, as much as possible, if drugs are not essential, give it to them. So somebody asked at the community level, why are you excluding pregnant women? I said, well, it can be dangerous. Then somebody, is it dangerous? Then in your explanation, you open your mouth and say, well, if you are not careful, it can cause abortion and this and that and that. And then it becomes the abortion medicine. Backdoor work. We managed to get a resolution through, which called on member states to take advantage of the recent advances that have come up in the elimination process, as well as monitoring and evaluation tools that have been made available to strengthen programs with integration and also the control of other diseases in the same time. The Assembly called on member states to take up this initiative. Not just that, but they also asked that research and diagnostics for our laboratories in support of this program should also be continued. And most importantly, they asked that we mobilize resources to get this done, because without the resources, you cannot do anything. And therefore requested the Director General to bring this to the attention of all specialized agencies and countries and everybody. Those of you who are familiar with the resolution systems, this is a typical resolution to garner support at the global level, to mobilize support for global and national elimination activities. Basically, this is the best public buy-in at the highest political and governmental level that you can have, the World Health Assembly resolution. Lymphatic filariasis has it. But by 2005, out of the 38 countries in Africa, only 5 had effective programs. So when I was called upon to do an editorial, I invited my colleague Nana Chumdansu, I hope she's here, to join me in doing this editorial. And we raised several issues. And it was misinterpreted as drawing the program back. Sometimes when you say it as it is perceived as drawing the program back. But we need to confront these issues. And at this time, I want to borrow this slide from our colleagues in Tanzania who did some work on malaria, who raised very, very critical issues, what you may refer to as the health systems issues. You may have an intervention like ACTs or any of the anti-malarials that has an efficacy of about 98%, but an effectiveness of as low as 37%, because the intermediaries are just not functional. Access is poor, there are no effective diagnostics, there is no good provider compliance and patients adherence. And then when you even begin to look at it in the different quintiles of socioeconomic standing, then you are looking at something even worse. So an efficacy of 98% does not necessarily mean that everything is well. These are the systems issues that we need to confront. Our human resource issue I've raised, our delivery infrastructure, which is almost non-existent in some parts of the country and in other parts of Africa, no implementation resources, the oversimplification of the concept of integration as being the solution to all our problems. These are some of our highways in very remote areas. And sometimes you think you have a four-wheel drive so you can go. I mean, four-wheel drives do nothing in these environments. How do you eliminate a disease when the infrastructure is so poor? We need to engage the community to have a continuous buy-in. The whole problem, we are talking of elimination in Sub-Saharan Africa. So we need to think about the fact that disease elimination or lymphatic filariasis elimination is not restricted to Ghana. If Ghana does it and Cote d'Ivoire doesn't do it, we are nowhere. Mosquitoes know no boundaries. They don't need a passport. They don't need a visa to cross over. So we need to think about these issues holistically. Morbidity control is very critical. We need to get this up and running. The whole issue of having an effective pharmacovigilance system in place. Because in as much as these drugs are so safe, sometimes maybe 1 out of 1 million treatments or 1 out of 10 million treatments can end up in a very bad situation. And if you do not have an efficient system at the very end of the road, then you can run into problems. I recall very well a young lady in Hunter West who died because she had an acute renal failure, and the doctor who was managing this case decided to set up an IV line and was pumping in fluids, and the patient died because of, well, the problem was a drug reaction. These are real problems that we need to deal with. When such things happen, you need the regional director, the district director, and the chiefs to put away one whole day to go and mourn with the family and explain things to them to ensure that next year the community does not abandon the treatment. Otherwise, all the work that we are doing will be brought to naught. our morbidity control, the treatments that we are giving, I would say, are preventing the future generation from getting the disease. What about those who have the disease now? What are we doing for them? Hydrocele surgeries, which are very simple, the simplest surgery that one can do. Yesterday I was talking to somebody and he asked me, how much is hydrocele surgery? And I said, well, at the time that I used to do them, they cost the order in something in the order of about $50, which is about 75 or so cedis. Then the person said, oh, that is cheap. I said, oh, $75 75 cedis is cheap for you. But the people who have these problems do not even have 5 cedis to go to the next level of care. So we need to think of how to take care of these issues. So having said all this, my question is, yes, there are challenges. Yes, there are problems. So how do we make lymphatic filariasis elimination a fact and not a fantasy in our environment? We need to put in place very effective monitoring and evaluation systems. We need funding because it is key. They say, Sika Emoja. Without it, on the same platform, we need to strengthen the health system to make it more efficient. And advocacy at all levels is critical. As far as monitoring and evaluation is concerned, through all the consortium of work that we do with the World Health Organization, now we have very effective manuals to guide program managers on how to monitor, implement, and evaluate programs so that you can know whether you are on track or not. But funding. I want to suggest that we need to have champions for lymphatic filariasis and other neglected tropical diseases in Africa. President Clinton has been championing polio. Jimmy Carter has been championing guinea worm. We have 2 retired presidents in this country. We need champions. We need people to take this up and be associated with it, to be associated with their foundations, so that people can begin to say that, oh, President Kufuor is associated with this, and therefore people are willing to have a buy-in. Oh, President Rawlings is associated with this, so they want to have a buy-in. Our former leaders need to be engaged on some of these platforms so that they can help mobilize the resources and the political capital that is required to get these interventions in place. We need champions. We need advocates. We need flag bearers. And we need to engage and encourage local philanthropy. It is so amazing that in this country there are many people who are considerably wealthy and can invest in the health of our environment. They can invest in the health of our people. But our priorities are not that right. Probably we have not engaged them well. Probably we have not shown them all these problems yet. And we need to have a system where it's not just for disease control, for education, setting up foundations. In the US and in the UK and Europe and other places, it is possible for people to go to school once they are brilliant and can make the good grades. They can apply for grants and be able to access some of these grants. What are rich people doing? And I want again to advocate for something which might appear very controversial now. I think that the National Health Insurance Authority, and the scheme for that matter, should begin to invest in public health interventions. We are sitting down and allowing the people to get sick, and then they come to the hospital, and then we pay their hospital bills. But we don't want to invest in public health interventions. I think this 2.5% VAT that is being mobilized for the National Health Insurance Scheme is quite a substantial amount of money. And if we were to prioritize very well, in my view, in my humble opinion, it is very possible that some of these public health interventions could be funded through the National Health Insurance Scheme. Coordinating mechanisms. We need harmonization at the national and global level. Sometimes we just get overwhelmed with all the partners. Sometimes the way they gather is like hawks gathering when there's some carcass somewhere. Many of our so-called NGOs, unfortunately, are seeking their own interest first. These days, many people who come to the School of Public Health are coming for an MPH so that they can join an NGO. And I'm told that this year, everybody doing epidemiology has dropped advanced epidemiology on Friday. They waited till the last day of add and dropped advanced epidemiology, which will make them epidemiologists, go on study to become so this year nobody is studying advanced epidemiology in the University of Ghana. I think it's a shame. When the logos finish populating, then I'll stop. Everybody says they are doing something because of the resources that are available. And they have very interesting names. And they all come very nicely. And we receive them, and they manage our programs for us. They go and mobilize resources on our behalf and come and do things. Of course, some are good, but I think the majority of these could be managed better if the public health division were to be giving these resources that are coming from all these NGOs that are operating in Sub-Saharan Africa. I believe Dr. Mankwa will be extremely excited and will move all our disease control programs forward in the right direction. The Minister of Health, when he was appointed in Rwanda, started listing the so-called health partners. And this is what they came up with. And he said, where is my Ministry of Health? Because all these people are basically running the things that the ministries should be doing, but they are not coordinated appropriately. Yes, we need help. Yes, we need partnership, but we need coordination above all. So back to my topic. We have many different worms, from the ascaris to the schisto to the hookworm to the roundworm to filariasis and all that, and many different vectors for carrying these diseases. But they are all integrated into one patient. If you see somebody with elephantiasis, it doesn't mean that person is not entitled to onchocerciasis. The patient is not interested in individual diseases. All he wants to do is to get well. So as health workers, we need to bear this in mind. And indeed, the interventions that we are providing cut across all these parasites. And therefore, we have a very good opportunity to get rid of many more parasites around if our programs are coordinated better. Indeed, many of the people who take our treatments are very much excited, not because of filariasis or onchocerciasis, but because of scabies. You know scabies? What do they call it? What are the local names? I've drawn a blank. The local names for scabies. Tonkonatiti, yes, that one. Is that when you are scratching, then you are sleeping. Yes. Many people are very excited about the relief they get for scabies rather than for onchocerciasis or lymphatic filariasis. Basically, we can have better mileage with these medications. So we should make integration, in my view, an attitude and not a strategy. Where things fit, put them together. Where they don't fit, do them separately. Look for ways for coordinating and move ahead. Talking about the health system, some people are so protective of the health system. I'm not of that group of people. A health system needs people, money, information, supplies, transport, communications, whatsoever, to deliver interventions. So if there's a health system that is not delivering interventions and is just thinking on delivering, developing these things, then it's not an effective health system. So it must deliver interventions. But we need to protect that intervention. We need to protect that system. We build upon it, and where the system does not reach, we should use tested delivery mechanisms that have been shown to work to deliver these interventions. Beyond all, I think an investment in the social and developmental environment is key. Many of you will be surprised to know that Japan had lymphatic filariasis. Japan had lymphatic filariasis. Elimination or eradication of lymphatic filariasis from Japan came through socioeconomic development. So that is the ultimate. In this day and age, I still wonder why we are building open drains in this country. We are building open drains. Many of these drains end nowhere because they've been given to party faithfuls as contractors to make sure that there is job for the boys. It didn't happen only in this government. It started before and has been with us for a very long time. And it's still continuing. Why are we building open drains in this day and era? So we need to ensure that we engage the health system efficiently and make sure that it works well. Advocacy is critical. And one of the key partners we have in advocacy has been the press. We've had very interesting working relationships with the press. Onco drugs scare patients. Somebody says one thing, and these days, because of the radio systems that are around, the FM radios, information moves so quickly. Rumor mongering, actually, I should say rumor mongering, which can be a deterrent to an effective program. So yes, the press can be a good advocate if they do their work well. Sometimes they totally misreport us. New onco vaccine in the offing. I was in this meeting and we're discussing doxycycline. Doxycycline is one of the derivatives of tetracycline, and it is being tested to see whether it will be useful for onchocerciasis. We held this meeting at Shangri-La. I was so lucky. We were chatting, and somebody called me, and I turned my face, and then the cameraman just clicked. So my face is not there. But you can see Dr. Kofi Ahmed. You can see the current chief executive of Komfanoche Hospital, Professor Ohineji, and the 2 Germans over there. I was the 5th person. I think the Holy Spirit that gave me leading. And they put it headlines: new onco vaccine in the offing. So I get a call from Ouagadougou. Johnny, what's happening in Ghana? These days, everything is online. You work with them, you actually give them a summary, an executive summary of what it is that you have done as far as your research is concerned. They put it aside and write their own story. Walking barefooted can cause elephantiasis. Professor Binka and Professor Kwame Kakari found some money, and we decided that let's educate the press and the media. So they brought them all to Navrongo. So many of them. And we talked about everything. So after I've given the talk on elephantiasis, then one of the people asked, so is this the only cause of elephantiasis? And I said, oh, well, there are other possible causes, especially it's been reported somewhere in Ethiopia where people who walk barefooted get silicon deposited in their lymphatics, and it's called podoconiosis. The next day, banner headline: walking barefooted can cause elephantiasis. And then they say, happy weekend. So I'm sitting in Navrongo. Those days,